The numerous and sometimes devastating complications of traditional glaucoma filtration surgeries, such as trabeculectomy and drainage implants, are well known. Recently, a class of procedures being dubbed minimally invasive glaucoma surgeries, or MIGS for short, have emerged, touting far fewer complications and faster visual recovery. These new procedures, however, lack the efficacy of traditional filtration surgery and don't consistently achieve the low pressures necessary for some patients. So some surgeons are now combining multiple MIGS procedures in an attempt to keep the excellent safety profile of MIGS while improving the efficacy to approach that of traps and tubes. One such combination has been dubbed the ICE procedure for iStent, cataract, and ECP. I had a patient referred to me in February 2013 for combined cataract and glaucoma surgery in the right eye, who had moderate progressive field loss with IOP in the 17 to 20 range on maximum medical therapy and unresponsive to ALT in the left eye. I wanted a rapid visual recovery for him, but I also wanted a little more efficacy than iStent alone could provide because he was on maximum medical therapy and experiencing progressive disease, so I chose the ICE procedure. I prefer to start by implanting 2 iStents, then doing the cataract surgery, and finally finishing with ECP at the end of the case. 2 iStents have been shown to achieve lower pressures than a single stent, so if it's feasible, this is a good way to improve efficacy. The addition of ECP at the end of the case may help further reduce IOP and/or medication burden without adding too much risk. The patient's IOP settled in the 10 to 13 range with a reduction in medication burden over 4 years of postoperative care. Most importantly, his visual fields appear to have stabilized and his disease seems controlled. ECP can also be combined with any of the other MIGS procedures, such as the ab interno trabeculectomies done with trabectome or Cook dual blade, and also the various circumferential trabeculotomy surgeries done with either a lighted micro-catheter or the Trab 360. Let me share with you another case to help illustrate combined MIGS. In April 2013, a POAG patient was referred to me with severe progressive field loss in the left eye with IOP 21 on maximum medical therapy. He was pseudophakic and was a high myope who had undergone a scleral buccal RD repair in the left eye in the distant past. He needed surgery, but the traditional options of trab and tube were worrisome for various reasons. We chose to try trabectome and 360-degree ECP instead to minimize the risk for complications. He did very well postoperatively with IOP settling in the 10 to 14 range over 4 years of post-op care, and his visual fields have remained stable since the surgery as well. Let's now take a look at a video of Trab 360 combined with ECP as an example of this type of MIGS combination. For surgeons accustomed to iStent, trabectome, and Cahook dual blade, the large size of the Trab 360's tip will initially feel awkward. When piercing through TM, if the tip hasn't been placed far enough into Schlemm's canal, the Prolene catheter will slip out into the AC. If this happens, just advance a little further into the canal and redeploy. Once the catheter is fully extended, push the tip in the direction of the catheter before pulling the device towards you to perform trabeculotomy. Repeat in the opposite direction. Finish up with ECP 360 degrees through 2 incisions for maximum effect. This combination has proven useful for me in those who have failed consecutively both trab and tube. Up until now, we've only seen combinations of ECP, an inflow mechanism, paired with an outflow MIGS procedure, but it is also possible to combine 2 outflow MIGS procedures. Limited sectoral removal of trabecular meshwork with either trabectome or Cahook dual blade can be paired with circumferential ab interno canaloplasty performed with a lighted microcatheter or the Visco 360 device. Here's such a case. In May 2015, a 77-year-old lady was referred to me with cataracts and newly diagnosed POAG. IOP had been reduced from 18 to a range of 13 to 15 on Zalatan alone. Unfortunately, she already had severe field loss. I did not want to do a traditional filtration surgery at the time of her cataract surgery, as I wanted to give her a rapid visual recovery. I opted instead for phaco with ab interno canaloplasty augmented with ab interno trabeculectomy. First, pass the microcatheter into the AC via a paracentesis. Apply the gonio lens with care being taken to not trap the microcatheter under the cleat ring of the gonio lens. Perform a Cahook dual blade ab interno trabeculectomy in the usual fashion, except in this case don't remove too much. You want to be able to see the edge of intact TM so you know the catheter has indeed passed into Schlemm's canal. Thread the catheter all the way around the canal.
when ready to perform viscodilation, support the catheter with an instrument to prevent cheese wiring, and then slowly withdraw while your assistant injects aliquots of OVD. Keep the catheter moving to avoid Descemet detachments.
She did very well postoperatively, with IOP sitting in the 7 to 10 range over 18 months of follow-up of all medications. Micropulse has recently emerged as another gentle alternative to ECP that can be combined with MIGS procedures. It's advantageous in phakic patients and for cases combined with cataract surgery because it produces little to no added inflammation.
I find it helpful to mark the micropulse probe to help me to keep it oriented in the right direction during treatment. I treat 4 quadrants rather than the typical 2 hemispheres. This patient is a 74-year-old with POAG and IOP 22 on 4 medications with -8 decibels of progressive field loss. I now perform ab interno canaloplasty with a Visco 360 device. I augment this with a Cahook dual blade trabecular removal. At post-op week 6, this patient had an IOP of 9 on 2 medications.
My personal experience with combined MIGS has been very encouraging. For my small group of 22 open-angle glaucoma patients, many of whom had significant field loss, it has proven to be capable of achieving low pressures, reduce medications, keep a good safety profile, and produce good success rates durable through 4 years of follow-up.